Good afternoon and all. I am Dr. Niruban, Assistant Professor and in charge Department of Ophthalmology at GPMR Karaikal. GPMR Karaikal is a newer sister institute of GPMR Pondicherry. So this particular case which I am showing is a 60-year-old male with unilateral subluxation. This patient did not have any sign of subluxation in the OPD, just that anterior chamber was shallow. So only the presence of a shallow anterior chamber, unilateral shallow anterior chamber, was the reason which I suspected subluxation in this patient. So as you can see, with a very little amount of visco being injected into the eye, you can see most of the visco being egressed out. So that's shallow the artery chamber was. And the second aspect is on making the rhexis. So when the needle is placed on the anterior lens capsule, you can see the folds on the anterior lens capsule, and doing the rhexis gets difficult in cases of subluxated cataracts. So you need to move through the side port as well as the main port to go through the or to perform the rhexis. And in this patient I did not use trypan blue as well, so I was using the retinal glow only to perform the rhexis. So once rhexis is done, the next step being hydrodissection. Already the anterior chamber is shallow, so once the hydrodissection is started, you can see the iris coming out, and there was repeated iris prolapse, making the surgery even more difficult. And the mydriasis also was poor following this, so the size of the pupil reduced to almost 4 or 5 millimeters. And I did make sure that the lens is fairly rotating well into inside the back before I could proceed with phacoemulsification. Once I am sure that hydrodissection is complete, I inject very little viscoelastic and then proceed with phaco. So with phaco we can use techniques wherein the manipulation on the lens is less.
Niruban, can you stop here?
Yes, sir.
For a second, let's have a discussion up
Yes,
to
sir.
this point, because this is a very challenging scenario. Satya, how would you approach this patient where you suspected the subluxation on the table, and the way the case went on? What would have been your approach?
One thing is
Use the mic. You have a mic?
no. One thing is iris kept on collapsing. So what came to my mind is probably the fluid has gone through the zonal dehiscence and the vitreous pressure has increased. So that is one thing.
So
maybe I would have avoided pushing fluid over the anterior capsule. And second thing is I would have definitely put the capsular hooks or iris hooks and then go ahead with the surgery, rather than waiting for this thing to happen, something else to happen.
Dr. Kashyap?
I would have made a lifeline, that is a pars plana, trocar canula, and then do a little bit of vitrectomy if the AC was becoming so shallow, and then I would have taken the help of the trypan blue, and probably if the hooks were required, I would have done that.
Okay. Dr. Sunil, one comment?
Yeah, definitely you have to don't manipulate when the iris is relaxing that much. Don't manipulate through the same. Manipulate from somewhere else, put it in. That is one thing. The other thing is either you put in some midracane or phenocaine or something. Handle the iris. Put in the hooks. Don't continue with the phaco with the iris keeping on coming out like that and shutting down only, because you are going to increase your chances of complications like anything. Once you put in the hooks and the iris retractors, I think it will become easier. It will become easier.
No, I think Niruban, was doing a case, and things are getting more difficult and difficult.
This was a topical phacoemulsification, so
Yeah.
I avoided
I think
iris hook.
Few important points which people have to understand if you have a subluxation as a suspect. The first thing is, to have a very nice visibility, dilate the pupil well, and stain the capsule in a more darker way so that you can see the rhexis thing properly. And subsequently also you may have to handle the rhexis by hooking the rhexis with the capsular hooks, or you want to put some other devices. The rhexis will be visible. So that should be done before the hydro procedure, so that your visibility of a rhexis margin becomes not that clear once you do hydrodissection. And rightly said, the pupil expansion would have been better to manage the case in a more simplified manner. And with the repeated iris getting handled, two hooks would have also created a nice.
When 4 or
opportunity.
5 hooks are placed,
Yes.
the
Let's see how the case goes
Yeah.
now. Niruban?
yes, sir. So proceeded with phacoemulsification. I personally don't prefer inserting CTR without before removing the lens. So I did proceed with phacoemulsification, and so the main technique which you have to use for phacoemulsification is the one which you don't keep on trenching, so that you increase the zonal dialysis. So minimize trenching. You can chop it, and you can do a direct chop and do the rest of the phaco. So once the phaco is done, I did attempt I&A. Until now, I did not see any sign of a zonal dialysis. It seems apparently okay, so I did attempt irrigation and aspiration, and you see what happens. So the bag is getting folded, so I stop there, and then I insert a CTR. And when the CTR is being injected also, you can see that the bag is very loose, and maybe half of the CTR, when it goes inside the bag, only then you see that the bag gets stabilized, as you see now. Yeah, so now the bag is it seems stable. So the CTR is inside the bag, and I switch over to a Simcoe instead of IA cannula, because there is controlled irrigation aspiration of the cortical matter. So once the IA is done, I inject the intraocular lens into the bag, and here again careful maneuvers are to be used, wherein there is a controlled release of the IOL rather than a sudden release, and dialing it into the bag should also be a very gentle maneuver. You just place the haptic in the bag rather than dialing it, and the final irrigation aspiration of the viscoelastic is also done by the Simcoe cannula. So these are some important points to be followed during subluxation, operating on a subluxation of lens. And this is the 1 week post-operative picture of this patient. There is some minimal edema over the section, and vision is 6/9. This is another case, unilateral subluxated lens. This patient underwent trauma to her eye with a broomstick, and you can see almost 270 degrees of subluxation here, and the lens is grossly shaking inside the eye. So in such cases, I would prefer to do an SICS, do an ICC, and then plan for a scleral fixation of IOL rather than going ahead with phaco. So an ICC was done to remove the IOL with the capsular bag, and I use a 3-piece IOL and suture it or anchor it to the sclera using the X-knit technique. So since the subluxation was more, around 270 degrees, I would rather go ahead with ICC in such cases rather than phaco. This is the picture after the surgery. Thank you.
Wonderful, Niruban.
Thank you, sir.
What about the retrofixation of IOLs in such cases?
Yes,
you
sir.
practice
That
that
is another
also?
option. That is another option wherein after ICC, iris claw lens also can be placed.
How long is the experience of yours in terms of retrofixation IOLs?
There was
Okay.
one more surgery which I did on using a retrofixation of lens. Following, it was a primary sitting only.
Okay.
ICC using an SICS tunnel and then retrofixation of lens.
Thank you,
Welcome,
Niruban.
sir.
It was a very nice presentation. So he showed difficult scenarios. Sometimes like case like second case where you have such a huge subluxation, no point struggling to fix a bag and doing phaco, and ultimately you will not be able to fix the entire bag in the proper area. You have to do a simple SICS, take out the nucleus and lens, then put a fixation device